And we will start. The first speaker, Gian Paolo Fadini. Gian Paolo Fadini, Associate Professor of Endocrinology and Metabolism at the University of Padova, Associate Medical Director of the Division of Metabolic Diseases of the University Hospital of Padova, Barcelona, Spain. He will talk about hyperglycemia, glucocorticoid therapy, and the outcome COVID-19. Professor Gian, please.
Thank you, Mr. Chairman. Thank you again for inviting me to this hybrid virtual meeting. Yesterday, I had the opportunity to discuss about one of the most hot topics in the field of diabetes and COVID-19, that is the relationships between glucose control and outcomes of this new viral disease. Today, I will go deeper into how glucocorticoid therapy can affect such relationship. This can be an area of great interest for the diabetologist and also for all physicians who are involved in the care of patients with COVID-19. We left yesterday with this complex interaction. There are still a few question marks here. There should be no debate that hyperglycemia is associated with worsening conditions in COVID-19 patients, that such worsening drives poor outcomes, and patients in such disease stage are likely to receive glucocorticoids because of severity of COVID-19. And of course, glucocorticoids will inevitably worsen hyperglycemia, driving a vicious cycle. We will try to dissect how much glucocorticoid therapy is confounding the relation between diabetes and hyperglycemia and COVID-19 mortality. And I will also try to provide you with some practical recommendations. First of all, I would like to review the evidence that glucocorticoid therapy can be useful in patients with COVID-19. The most important study we have is the one performed by the Recovery Collaborative Group, shown here. The study was performed in more than 6,000 patients with COVID-19 who were randomized to receive dexamethasone 6 milligrams once a day for up to 10 days or standard of care. The primary outcome was mortality at 28 days. Overall, 25% of these patients died, which is a very high proportions compared to what we're seeing, for instance, here in Italy. So this mortality rate is overall indicative of a severe form of COVID-19. Considering all patients, mortality was significantly lower in the dexamethasone group than in the control group, with a relative risk reduction of 17% and an absolute mortality reduction of 2.8%. The other most important finding here is that patients who benefit from this therapy are only those receiving respiratory support, being either invasive ventilation or even only oxygen supplementation. The benefit was particularly evident and strong for those receiving invasive ventilation, those who were intubated. On the other side, dexamethasone provided no benefit at all in patients who were not receiving oxygen, for whom there was a clear trend toward poorer outcomes, that is, greater mortality in those who received dexamethasone than in those in the control group. Results are shown here in a slightly different way, and you can easily appreciate how different was the effect, the benefit of dexamethasone on mortality according to the type of respiratory support the patient was receiving, and that the effect in those who were not receiving oxygen support was not so far from statistical significance, showing a worse outcome. Here, I would like you to note that about 25% of patients enrolled in this study had diabetes, but unfortunately, no stratification has been performed for diabetes status, which is a pity, at least for us, because hyperglycemia is, of course, one of the most obvious short-term side effects of dexamethasone. The second good study we have is the CODEX randomized trial. This is a much smaller trial conducted in Brazil, involving patients in the ICU who were randomized to receive high-dose dexamethasone, 20 milligrams, or standard of care. The primary outcome was ventilator-free days during the first 28 days of hospitalization. You see the results here. Dexamethasone increased time free from ventilator support by about 2.3 days, so not so strong an effect, but exerted no effect on mortality. You see the survival curves appear to separate early, but finally converge at the end of observation, showing no overall difference between the two groups. In this study, about 40% of patients had diabetes. Use of insulin to control hyperglycemia was similar between the two groups, but there was no outcome data stratified by diabetes status again, and no information on glucose control, which is again a pity for us. In order to understand how much this therapy could affect glucose control, I put here the glucocorticoid conversion table. Just to remind you that 6 milligram dexamethasone used in the recovery trial corresponds to 40 to 50 milligram prednisone equivalent, whereas the 20 milligram dexamethasone used in the CODEX trial corresponds to 130 or to 150 milligram equivalent, which is a more than immune suppressive dose. How much this dose acutely affects glucose control, it is not easy to say. I found an old study in patients with type 1 diabetes using CGM, reporting that insulin requirement after a 60 milligram daily dose of prednisone is almost doubled, and even so, hyperglycemia is not well controlled. It should be mentioned that in patients with type 2 diabetes, contrary to the assumption that insulin resistance is the main driver of glucocorticoid-induced hyperglycemia, results of pathophysiologic studies indicate that decreased insulin secretion is more likely the cause of worsening glucose control. This is interesting also in view of the observation that I've shown to you yesterday that SARS-CoV-2 might in fact be the cells leading to decreased insulin secretion. There is another interesting study in people with type 2 diabetes and in those with normal glucose tolerance, showing that the effect of a much smaller dose of prednisone indicate that treatment of prednisone-induced hyperglycemia should take into consideration a few issues: a rapid onset of relative insulin deficiency, a delayed reduction in insulin action on target organs, that is insulin resistance, occurs after reduction in insulin secretion, and that these effects overall lasts less than 24 hours, meaning that it is changing during the day. So these are important information to be taken into account when choosing the right therapy, usually insulin, and the right schedule of therapy to control glucocorticoid-induced hyperglycemia at those very high dosages. Well, of course, there is no debate that glucocorticoids increase glycemia, but even with such certainty in our mind, there's a review here that suggests that there are many unanswered questions, and one is related to the well-known variability among patients in the extent to which glycemia increases after or during glucocorticoid therapy. That said, what we know about hyperglycemia, glucocorticoids, and COVID-19? Well, it has been hypothesized formally that in-hospital glucocorticoid use may mediate the detrimental effects of hyperglycemia on COVID-19, especially in patients without a history of diabetes. Again, there are several possible complex links. I have described two possible situations here. On the top, in patients with SARS-CoV-2 infection, use of glucocorticoids at home for worsening symptoms may cause admission hyperglycemia once they are hospitalized, if they are hospitalized. And in this case, of course, it is more likely that this admission hyperglycemia is just an epiphenomenon of disease severity for which the patients require the glucocorticoid, and it might not directly contribute to the outcome. On the other side, on the bottom of this figure, we have another possible scenario. The patients with COVID-19 can develop hyperglycemia, as I mentioned yesterday, which is indeed associated with worsening conditions, possibly leading to hospitalization and need for glucocorticoid therapy. Glucocorticoid, in turn, would worsen hyperglycemia and at the same time improving the outcome only in those patients who require respiratory support and oxygen therapy. So in the end, there's a vicious cycle where hyperglycemia contributes to maintain the risk of this patient. And of course, it is at least in part driven by steroids. So we tried to dissect this possible complex interplay in our study. And you see here the effect of each 2 millimole per liter of fasting plasma glucose increase and its effect on poor COVID-19 outcomes that in the study was admittance to the ICU or death in the entire population, not stratified by glucocorticoid use. But when we adjust for pre-admission use of steroids, the effect of hyperglycemia was completely lost in those who used the glucocorticoid steroids, the glucocorticoids at home. So this means that purely steroid-induced hyperglycemia may not be associated with worse outcomes. But by looking at the numbers, you also see that it is not associated with good outcomes. So in these patients, the hyperglycemia might offset the beneficial effects of glucocorticoid therapies for COVID-19. On the other side, adjusting for in-hospital use of steroids did not modify the association between admission hyperglycemia and poor outcomes. So this suggests that hyperglycemia in COVID-19 patients remain a predictor of bad outcomes, even in those who need it and in those who did not need in-hospital glucocorticoids. However, glucocorticoids is expected to worsen glycemia in these patients. So we urgently need an analysis of the two trials that I've shown to you before with stratification for diabetes stages and glucose control. In the end, I think we remain with the main question of whether the trend to higher mortality among patients without need of oxygen who receive dexamethasone, shown in the recovery trial, may be mediated by worsening glucose control. It is, of course, a matter of balance between the benefit of glucocorticoids on inflammation and immune activation during COVID-19 and the harm, on the other side, we could do to our patients, which is particularly mediated by hyperglycemia. So finally, I have a few take-home messages and practical recommendations. First of all, I hope I have shown to you that glucocorticoid therapy provides benefit only in patients with severe oxygen-dependent COVID-19 related pneumonia, and no data are so far available for patients with diabetes. So glucocorticoid therapy is not recommended to treat COVID-19 at home, but only in those who are hospitalized who require oxygen. So in all patients, glucocorticoids are expected to worsen glycemia, even in those without history of diabetes without pre-existing known diabetes. And glucocorticoid-induced hyperglycemia may counterbalance glucocorticoids' protective effects against respiratory deterioration and death. And so high-dose glucocorticoids should be evaluated carefully in each patient because the benefits might not be more than the harm we risk to do to our patients. So these were my take-home messages. Thank you for listening, and I will now be pleased to address your questions.
Thank you, Professor Gian, for this elegant lecture. And the message is crystal and clear that we have not to use glucocorticoids at home at all. If it was indicated, we should take it at hospital, and only for patients who has problems in their oxygen. The floor, if there is any question, please. Yes?
How to manage hyperglycemia due to glucocorticoid in COVID infection by basal bolus therapy, insulin basal bolus.
Professor Gian?
Yeah, I'm
He
not
asked
sure you
about
heard
how to
the
manage
question
patients
because
who took
the question was
glucocorticoids in
about how
COVID.
to manage glucocorticoid-induced hyperglycemia. Is that correct?
Yes.
Yeah. Okay. So we have to take into account a few issues that I've shown to you. First, is that the primary effect of glucocorticoid is insulin deficiency. So this is the first effect that it is emerging after glucocorticoid administration. Later, you have insulin resistance. And finally, you have to consider that all this lasts less than 24 hours, but this depends on the schedule of glucocorticoid use and the half-life of the molecule we are using. However, that said, it is clear that when we use glucocorticoids, especially at high dose, in the hospital to treat COVID-19 with respiratory deterioration, glycemia should be controlled with insulin most of the times. Okay? And what type of insulin we should be using? Probably we should be using an first generation basal insulin first, administered in the morning with a half-life of around 18 to 12 hours would be ideal to control for hyperglycemia. Probably patients would need also fast-acting insulin like a rapid or ultra-rapid insulin, that is maybe even the human regular insulin at meals, especially at lunch, because the effect of glucocorticoid would become more apparent after lunch and before supper. So generally speaking, this is the supposed to be the most common and most rational schedule of treatment of glucocorticoid-induced hyperglycemia in the hospital for most patients. So a first-generation basal insulin with not so a long half-life and a rapid-acting insulin probably at lunch.
Thank you, Professor Gian. Another question? Okay, thanks, Professor Gian, for this elegant lecture, and see you again, inshallah, soon. Thank you very much.
Thank you. Thank you. Bye-bye.